So first question might be for you, Cindy. How can we get copies of speakers' PowerPoint slides?
Okay, so I did announce this morning, and I will remind people throughout the day. Yesterday's are up. The videos are up at the site. Today's the videos will be up. The PowerPoints have to be converted, and they will also be uploaded at the site. I promise you they will be at the MSA Coalition website. Just have patience a little bit and give us a little time to get them up there, but they will be.
Okay, so I guess I'll just go through these and then distribute them as we go along. So this first question is, if bedridden, should patients wear compression stockings or waist abdominal binders during transfer to Barton chair to eat? And Dr. Gerardo, you can weigh in on this if you want. I would say, again, the compression stockings, in my experience, are difficult to get on, and you know, I haven't seen as much benefit from those that is kind of worth the discomfort. An abdominal binder I would recommend. I would say if it kind of largely depends on if you're having symptoms when you transfer. Some patients, even going from lying flat to sitting, can have quite a bit of lightheadedness. So I would say it just depends on if you're having symptoms or not, and if so, yes.
Yeah, I agree, and I think the speed of the transfer is probably very important. If you transfer fairly slowly, chances are you will not have significant issues with the orthostasis. The abdominal binder is, I think, is very effective. I agree with Dr. Miglis, and it tends to be more effective than elastic stockings, but sometimes it may not be completely practical. So if you like to use elastic stockings, the best, the simple thing I usually tell my patients is the higher the better. The higher either on your trunk, so if it goes up to your belly button, like pantyhose, so to speak, that's actually probably ideal. Or if you have to be less, say by your knees, you can't get it above that, then you need a higher pressure. And then that brings up Dr. Miglis' point. It can be pretty difficult to put on and off, but you can nowadays actually, they sometimes sell them with special holders, or helping gloves. You can come with some gloves and put them on if you need to do so. But if anything is difficult, I recommend, doing the transfer slowly. And that usually bypasses this issue. And also preferably do it after you've taken your medication. So if you are prone to significant drop in the blood pressure during transfer, make sure you take a little bit of Midodrine or whatever medication you're on half an hour before, and that reduces the likelihood of blood pressure issues during transfer. Oh, really? Oh, okay. So what I said is, I think perhaps everything aside, what matters is the speed of the transfer, and if that remains problematic, maybe perhaps take a medication half an hour or so before your transfer. So take the Midodrine, have it by your bedside in the morning, and then wait about 20 to 30 minutes, then do the transfer, and you're less likely to have a problem with the blood pressure.
Thank you. Okay, next question. This is for Dr. Yang. What dose of Sinemet do you titrate up to before you decide treatment has failed or is ineffective?
So with Sinemet, there is no standard. It's not like you can look in the books and there's something that's everyone does. But I tend to do 2 tabs 4 times a day. If literally nothing has happened, then I kind of think about it's probably not going to work. But that's general. But it's not like in the books or anything like that.
Sure. So the question is, what causes the involuntary spontaneous vocal stridor? So MSA, so for vocal cords are the window to breathing. I mean, it's like your window to air. Vocal cords open and close, and that's how you can phonate and make speech, right? So there are 2 muscles that do that. They call the abductor, abductor muscles. Those are the muscles that basically open the windows, the vocal cords. And then there's adductor, adductor muscles, which close the vocal cords. So if those muscles are affected, then your vocal cords either can't open completely, so then you'll have some degree of hoarseness or stridor. And if you're trying to breathe in, but the muscles that close the vocal cords are active, then your vocal cords, your windows are partially closed, so you're going to have some degree of hoarseness or stridor. So it's really the reason why the stridor happens is because the muscles that control the vocal cords are affected.
Thank you. So these are two questions, pretty much the same question, which I think is coming up quite frequently. So the question is, medical marijuana came up during the panel yesterday, but do the professionals have thoughts about CBD and THC for treating MSA? So I guess we can all weigh in on that. I would just say, from an autonomic perspective, we just have to be careful with some medications. Medical marijuana, because like alcohol, it is also a vasodilator, so it dilates the blood vessels, and which can drop your blood pressure. Of course, if patients are going to use a form, CBD is always better. It's less hallucinogenic and more mild. So there's a lot of benefits to it, but I think there's a lot of unanswered questions and a lot of research that needs to be done. And I would just say, not a big objection, but just be careful. Yeah.
I think along those same lines, agreed that everything we talk about is what is in the research, what we counsel, and then there's also from experience, which is not in the books, either yet or And so I agree, be cautious with it. I think in terms of the movement part is kind of the dystonia I was telling you about, the contractions, that kind of thing, and the stiffness and slowness. Of course, anecdotally, yes, I've heard some people feeling better afterwards, but you don't know if it's because they're also happier or they have a better appetite or so that's what research is for, right? Research is trying to get those other confounding factors out and making sure, is it truly that? So I would agree to not totally objecting, very open-minded, and I think most professionals say open-minded, but just not sure quite yet.
I think the marijuana can be used for insomnia and for what I do. So again, I echo Dr. Mitkus and Dr. Yang's comments. Is I think it does help insomnia. The evidence is not clear there, but my patients who don't have MSA, who have insomnia, tend to take marijuana and they do feel better. But again, we don't know exactly why. But you have to take into account the other potential side effects of marijuana with some of the other MSA symptoms.
Yeah, and I agree with what has been said. Neurochemically speaking, the endocannabinoid system, which is the neurotransmitter system in the nervous part of our body that has the receptors for the cannabinoid, marijuana, etc., is usually spared until very late in the disease. So it's usually not affected in MSA. But our patients do tell us, if they have, for instance, particularly when they start having the stridor, there is a component of anxiety, and sometimes, a little bit of a marijuana put them at ease. And, as my colleague said, also when they have a little bit of a pain or stiffness, that seems sometimes to play some role. And then, as Dr. Cow said, with the insomnia. But purely physiologically and pharmacologically speaking, those receptors in the brain are spared till much later in the disease. So I just want to emphasize that.
All right, we'll go back to an autonomic question. A few of these are the same questions, so they seem to be about medications used to treat the orthostatic hypotension. So what are the side effects of the common medications used for orthostatic hypotension? So as I briefly mentioned in my talk, just going through them, fludrocortisone, because it's a long-acting medicine, it is a steroid that increases resorption of fluid. It's not the best if you have a lot of very high blood pressures, especially laying flat. So in that case, we would tend to use the shorter-acting medicines like the midodrine or the droxidopa. All of the medicines increase blood pressure, right? So you never want to take the medicine and lay flat. You always want to, be sitting or upright, and you don't want to take it before bedtime. That's a common mistake that a lot of patients aren't told to do. The midodrine common side effect is scalp itching or tingling. It causes your hairs to kind of stand up, or goosebumps. Sometimes it can make the bladder symptoms a little worse, increase urinary frequency. And the pyridostigmine or the mestinon can cause sometimes GI upset or diarrhea. And any other side effects you had mentioned from those?
And if you're very sensitive, perhaps muscle cramps. Sometimes patients develop muscle cramps and benign muscle twitching from pyridostigmine, which is highly dose dependent. That doesn't mean you're allergic to the medication. You only need to reduce the dose or maybe space increase the interval between the doses. If you get these side effects, it's not an allergic reaction in the real sense of the word. Yeah.
Okay. And you can take this one as well. What is the prognostic value of very late onset or minimal autonomic features in MSA? Does the autonomic severity impact prognosis? I think that's what they're asking.
Well, I think, so the question is, what is the interrelation between the disease and the autonomic? And first, I think autonomic dysfunction is, at least in our experience, a constant variable for the diagnosis. If you have imbalance issues with ataxia, but with only minimal autonomic dysfunction, or if you have Parkinsonian signs with very minimal autonomic dysfunction, chances are you do not have MSA. So, to have really MSA, the autonomic symptomatology has to be quite prominent and early in the disease. Clearly, because of the slides, you've seen the slides Dr. Miglis showed, you've got the two major systems that are really affected. You've got the sympathetic system, which is very important, for how you interact with any stressors in your environment. For instance, your blood pressure can be a big issue. You're going to fall at risk of falling and having problems. Your sweating function is impaired, which means your capacity to deal with environmental changes in the temperature are affected. So you're much more prone, for instance, to heat stroke or heat-related issues. And then you've got the parasympathetic that's affected. So the digestive system is not working very well, and that can have a huge impact on your physiologic function and quality of life, frankly. And then the bladder function, and then the sexual function becomes very affected. So this gradually leads to dramatic, not only limitation, but also impairment in the quality of your life. And then, obviously, we know, at least in the autonomic specialties, every time the autonomic system becomes very affected, it does actually reduce the length of your survival. So, and that's not only just in MSA, but in actually many neurologic disorders. Once the autonomic system becomes affected, it increases, the chances of morbidity and, unfortunately, mortality. So I think that is one thing we're very, very actively looking at. How can we help the autonomic symptoms and signs, not only to improve the day-to-day quality of life of the patient, but also prolong their survival.
So this one's tremors. So how bad can they be, and how much worse can they become? So in MSA, tremors can be one of the symptoms for sure, and tends to more be the stiffness and slowness and autonomic. But yeah, you can have some tremors. I think maybe kind of what maybe you see on TV, like the big tremors in other diseases, so essential tremor and in Parkinson's, they tend to be a little bit bigger than the MSA one. MSA doesn't tend to always go that big, but it can. It's hard for me to say how worse can they be. It's very individualized. I can't say for a blanket one. It can, but I would say that the other symptoms are much more prominent than the tremors. Tremors is not usually the main one. And then there's also the prognosis of MSA or timeline. I think what the question's asking. I think what it's asking is like maybe life, the disease course, like the time of the disease course, or prognosis. Or prognosis, is always kind of guarded. We don't want, it's hard to say the exact year. It can be as much as 20. 10 is, I guess, average. But that's also, once again, very hard to estimate. But that's in general in the papers.
Dr. Cow, do you want to answer? Oh, we did this one? Okay. This question is, how often do you need to get a sleep study done after the initial one?
So in general, the sleep study is done number one, it's done to quantify or just to see if there's any evidence of breathing problems during sleep, right? And then also to determine if you need some kind of respiratory assist device. Once that's done, there is really no need to repeat sleep studies because the disease progression for sleep and breathing is not going to get better, really. I mean, it's, so we can pretty much manage the PAP devices in the clinic setting without having to repeat sleep studies over and over. The only time that I bring the patient back for a second sleep study is if the patient is on the breathing device and I can't seem to either manage the symptoms or the patient doesn't seem to synchronize or breathe well on the device, then I may want to bring the patient back for a sleep study, but it would be a study on the mask and the device to really see what's happening with the patient's breathing and the device. Like why is the patient not targeting the device? Are the settings appropriate? And so in that sense, I will bring the patient back. But otherwise, there's really no need to do a second sleep study. Now, if the first sleep study is unremarkable or very mild, and we're not doing any treatment, and your symptoms get worse, then of course it necessitates a second sleep study in the late, as time goes on. So.
And a quick, one more quick follow-up for you. Can you recommend an ENT doctor at Stanford if a patient has stridor?
Of course, yes. I work closely with my ENT colleagues at Stanford. So Stanford ENT is a big department, and there's different divisions. So you're looking at the laryngology division, which is the ENT doctors who do mainly, who deal with larynx and vocal cords and speech and so forth. So I think, there's 3 or 4 of them. Jennifer Lee is just, she's the medical director. She's great. I like her a lot. I use her a lot. I also refer to Dr. Sung. I think it's Chi Wang Sung. He's also very experienced with tracheostomies and vocal cords. So those are the 2 physicians I mainly refer to, but there's several more who I don't know as well.
We're going to do another question related to sleep, and I'll weigh in on it too, since you didn't talk about the neurological symptoms as much, which is my preference. So my husband has RBD, or REM sleep behavior disorder, and frequently he breaks out shouting and pummeling in the early morning hour. Any special reason why? Also takes 2 milligrams of Clonazepam and 10 milligrams of melatonin change meds. So REM sleep behavior disorder, or RBD, can be one of the earliest signs of these neurodegenerative disorders, MSA and Parkinson's, and also Lewy body dementia. And in some cases can occur up to 50 years before the other symptoms come out. In MSA, the time window tends to be a little shorter. But as Dr. Kao mentioned, the problem is because the areas in the brainstem that control the normal paralysis of your muscles when you're dreaming are not working because the disease has affected those areas in the brainstem. So, patients during dreaming will act out their dreams, and they can be quite violent, especially in men. And it's much more common in men than women, and the dreams are very, very can be violent. So. I'll weigh in on the medications, and then you can comment, I guess, too. But or you want me to just take this one? So Clonazepam was the drug that was used very early on when this was first discovered. In 1986, all the patients were started on Clonazepam, which is a sedating medication. So nowadays, we don't tend to use that medicine as much. We tend to use melatonin first because it can increase fall risk and change mental status and all of these things. So I would say if you're not responding to high doses of Clonazepam, I would tend to actually lower the Clonazepam if it's not working, and even lower the melatonin. 10 milligrams is a pretty high dose of melatonin, and there's some more recent research that shows that very low doses work better. Even as low as 1 to 2 milligrams at night. So I would say if it's not working, I would go down on the medicines first rather than go up on them and just ensure that the bedroom is safe. That means no sharp corners, nothing you can jump into, these sorts of things. But
yeah, so I think also if there's any suspicion that your bed partner is, violent or very active and that person is streaming, I think you really need to get a sleep study, because the sleep study can definitively diagnose REM behavior disorder, and you want to make sure there's nothing else going on. So there could be just a lot of body jerks, arm and leg jerks that is not related to the REM behavior disorder. So you really need the sleep study to really figure out what to do next. Okay.
So I have one. Which SSRI would you prescribe, and why not SNRIs like Cymbalta? So the SSRIs, so I tend to do that. They have a just longer track record. They've been around a little longer. So I do like sertraline a little bit more, but that doesn't mean it's better definitely than the other ones. SNRIs are fine as well, but I would always have active seeing if it's working, and there's so many options after. If one doesn't work, 4 to 6 weeks, wait, try a little longer, but there's so many options of it as well. But I just tend to go SSRIs, and that like I said, better track record, been longer around. Do you want me to do the second one too? So then there's a second one. This one's a little harder. So initially I experienced hand tremors. I typically started by dropping and increased potential for falls. Recently, I've had what I call full body convulsions, beginning with much more pronounced hand shaking, not just tremors. Have you ever seen this before? So I have like 30 more questions to ask this person. So whoever this is, you're welcome to, because there's so many things. What time of the day is it as you're waking up or falling asleep? Is this a jerking? Is this more only your hands? Is it, what do you mean by full body, hands and leg and trunk? So there's so many things that I would have to ask to really see. But I would say yes, there are other involuntary movements that can occur. Is this a type of dystonia? Different dystonias can have contractions too. So there are other movements that can occur along with MSA, and not just tremors and the stiffness and slowness.
So I have a more difficult autonomic question. So as all the difficult ones, I'm going to pass this to Dr. Girardet. He's much smarter than me. So the question is, what causes intermittent diaphoresis without changes in ambient temperature, both day and night, waking up with clothing and bedding soaked?
Well, first, as a disclaimer, I'm not sure I'm much smarter than he is, but I appreciate the flattery. The episodic sweating is actually a challenging symptom in autonomic medicine, because it's like the tremor, as Dr. mentioned. It can have multiple reasons why it happens. So first, if you have a partial decrease in your sweating, which, by the way, sweating impairment is a very, very common and actually a very early sign, diagnostic sign in MSA. But for a person who is beginning to lose their sweating, sometimes what happens early in the disease, the part of the body that still has sweat preservation paradoxically sweats excessively. This is a phenomenon in neurology, in neuropharmacology, we refer to as denervation sensitivity. So as part of the nervous system is losing its function, the remaining part becomes heightened and makes up a little bit more for that. So that could explain, usually in fact, why sometimes the sweating is excessive in a situation where normally you would sweat a little bit more, say heat. So early in the disease, it's common for the patient, when the temperature goes up a little bit, is that they sweat profusely. But then I usually ask them, where do you sweat? And often it's usually over certain body parts. So like they tell me, it's my forehead that's very sweaty, or the back of my neck, or my upper torso, and then the rest of the body really is dry. And that usually is a telltale symptom that perhaps we are dealing with this phenomenon. Occasionally also, because the sweat system in Dr. Mikle's slide is actually part of the system of flight or fright, if you get sometimes emotional, if your sweat function is totally intact, usually you only sweat small amount everywhere. It tends to be more in the palms and the feet. But when you have impairment in the sweating, sometimes these areas, the body areas have to make up for that. So occasionally you sweat a lot over these areas, and that makes it look like episodic sweating. The third reason for increased sweating is that we tend also to activate the parasympathetic system when we eat. It's rest and digest, but you also activate slightly the sympathetic. It's not totally dormant when you eat. And when patients sometimes eat, and if there is impairment, a partial impairment in the sympathetic, they sweat. So sometimes one of the signs we see is that the patients sweat profusely after they eat, even not necessarily because they ate something very spicy. So that's the third situation. The fourth situation, which probably is the more annoying one, is the one that happens at night. And when patients tell me they have excessive sweating at night, I usually, in my head, I have two things I think of first, is number one, are they having some type of a rapid eye movement sleep behavior problem, REM? Because actually during REM sleep, the sympathetic tone increases in the body, and then as it increases in the body, if you have partial impairment in sweating, that's when the phenomenon of supersensitivity occurs. So you sweat very excessively. So that's usually one thing, and those are the patients who say, I woke up and I had to change my gown, I had to change the sheet, the pillowcases, etc. That's usually, in my experience, a REM behavior related issue. And then the second thing I really worry about is your blood pressure changing dramatically during sleep. So sometimes, if your blood pressure increases and then decreases and oscillate, the phenomenon of the sweat gland is to make up sweat. And then during the daytime, if you are hypotensive, you remember from Dr. Miglis' slide, patients with MSA don't often feel incredibly lightheaded. In fact, sometimes they are asymptomatic until they faint. But one of the symptoms sometimes is that their sweating is excessive when they are up and around. And when you do blood pressure measurement during the daytime, it often correlates with the hypotension. So sometimes when the patient tells me, when I'm up and around, I'm sweating, particularly when I'm walking around, to me that's a sign perhaps they are having orthostatic hypotension and maybe I should tweak their medications a little bit. So I hope that answered that murky question, so to speak. It's very complicated.
It was very thorough. Thank you. You wouldn't think you would get 10 minutes on explanation of sweating, but that's what we do.
My sweating is better now.
So, Dr. Kao, do you want to answer those?
Yeah, so I have 3 questions here. The first one is I use energy shots. The caffeine seems to help. So I'm assuming the caffeine used is to help with daytime sleepiness and fatigue. I think that's fine. I think quality of life is very important on a day-to-day. So if the caffeine helps, I think that's fine to take. The only thing I will say is, you want to make sure you're not just masking some underlying problem during sleep that might interfere with your sleep quality and quantity, and therefore you're sleepy during the day and you're having trying to make up for it with caffeine shots. So number 2 is I'm on a CPAP. Is it okay to stop using it for a day or 2? So if the CPAP is used for obstructive sleep apnea alone, then I think it's fine to stop for a day or 2, especially if you're traveling for a weekend or something. But if you're using it really to keep your vocal cords open during sleep, then you should take it wherever you are, because that's, vocal cord paralysis. You can have sudden death with that, so it's important to really keep the CPAP on. So it depends on what you're using the CPAP for. Number 3 is I use REM Fresh. This is new on the market. It's a continued release of melatonin. So melatonin is over the counter. There are many different companies, brands, and so forth. It's not well regulated. We don't really know how much melatonin is in there. However, if you feel like melatonin is helping your sleep quality or quantity, then I think it's okay to take. Melatonin at higher doses it's a hypnotic. It basically it makes you drowsy. It helps you fall asleep. This formulation sounds like it's continuous, so it claims to help you stay asleep. I think if it does, that's great. I don't think there's any reason not to use it.
Just to piggyback on the melatonin question, because it comes up frequently. In the United States, melatonin is not regulated by the FDA, so it's considered a food. So we really don't know what the concentration is in any formulation of melatonin. Whereas in Europe, it's a prescription, so they know exactly what's being prescribed. Recently I've been recommending more liquid form of melatonin just because there's less filler in the pill, and you can buy liquid forms on Amazon, online. The time release form, there was just kind of a recent study that was recently presented that didn't really show that the time release was any more effective at treating the RBD than immediate release. But it was, maybe not the best study, but at least from that one study, there was not an additional benefit from an extended release form for that.
So this one's another interesting question. So my legs hurt and my right toes cramp, especially after eating. Why do they hurt, and what can I do to help? So I'm trying to figure out what this is. So still, of course, I do have a couple more questions to ask, but let's just talk about in general. Is this more of a muscle cramp, or is this a dystonia? Dystonias tend to be not dependent on eating. So the only thing, if I were to guess right now, more metabolic reasons, or even autonomic, in the sense that if it's something after eating, the first thing I thought, well, are you getting low do you have muscle cramps in general and then getting low blood pressure after, then also makes cramps worse. So that could be one thing that it could be. If it is more muscle cramps, the things that you can think about doing, one is, magnesium supplements can kind of help. Number two, if it is maybe related to, of course, and I'll ask my colleagues too, if it is related to blood pressure, you can try to take a smaller meal first and you can test this. So take smaller meals and not so high carbohydrate filled, just like what Dr. Migler was talking about, and see if that makes it better. Because this after eating part is very interesting. If you're having after eating, then try to change the eating pattern. So smaller meals, more frequent, and see if that makes it better, and then kind of go from there. But those are the two I think of maybe that this could be.
And then just getting back to the caffeine question, one thing that we recommend sometimes after eating, if blood pressure drops, is a little caffeine. And caffeine will increase blood pressure and constrict your blood vessels, so that's one thing that you might want to try as well, some coffee. So this is for Dr. Cao. Is the ResMed travel machine worth it for travel? Parentheses, no moisture.
You're talking about the Air Mini. The Air Mini is actually, it just came out within the last year. It's actually quite small and easy to travel with. If you're using a CPAP now and you are planning to travel a lot, I definitely think it's worth the investment. It's not covered by the insurance, but it's worth the investment because it's quite small and dandy. It doesn't have a humidifier. It sort of does. There's a kind of a makeshift version of a humidifier on it right now. It's not a true humidifier. So I think if your home CPAP and has a humidifier, of course, and if you definitely depend on that to be able to wear the CPAP for comfort and to sleep through the night, then you probably shouldn't get the Air Mini. However, what you can do is you can just go off the humidifier on your home CPAP for maybe like 3 nights or so and try it out. If you can tolerate that, then you can get the Air Mini. The new generations of the travel CPAPs will have the humidifiers, but the first generations don't. So hopefully that helps.
Okay. So I'll give one to Dr. Girardet. What is the best way to check the blood pressure of someone with MSA, example, sitting or standing?
I think it depends on, are you looking to see if the medication is helping and kind of checking the dose? So if you want to work with your physician and work on the medication, ideally it's, you want to measure it in all 3 positions. And many of our patients actually do so. They measure it when it's supine, and ideally you want to do it after you've been supine for a couple of minutes, and then they do it sitting up and then standing up. And I think that's probably the most useful. But aside from that, I think what really matters is between mostly sitting and standing, because these are most of your positions during the daytime. So if you have to do a couple of readings, those will be the ones. And then sometimes patients say, how often do I need to take it? I usually recommend 1 random measurement, usually early in the day, and perhaps 1 random measurement in the afternoon. But then you vary it depending on the patient and their symptoms. You may have to measure it before or after you eat, etc., etc. So, but I think usually sitting and standing is adequate, but if you want to do all 3, that's fine.
So there was a swallowing question. We do have speech therapists in the afternoon who they'll really have much more ideas than I do. But the question is it possible for pills to become lodged in the throat, not getting it into the system? What can be done if it feels like food or pills are caught? So the first thing I would say is swallowing is very, it can be unpredictable. And so what I try to do is the first thing I do, some main reasons that sometimes you get it stuck in is, number one, your mouth is too dry. So it's too dry and then you try to eat your pills and then it's harder to do. Or number two, swallowing is like an exercise. So when you warm it up, it actually is a little bit better. So usually when I have patients that are starting to have swallowing issue, I say, first, why don't you eat something first? So warm up your swallowing, whether it be applesauce or whatever you like. Take 3 or 4 bites, just get it warmed up, and then take your pills, of course, 1 at a time. That also moistens everything, so you've exercised it and you've moistened it, and then you try to eat the pills. But that would be the two things you could try. Other things that are kind of more obvious too. Number one, I know this seems silly, but it actually is true. Try not to be swallowing or eating food and doing something else at the same time. time. So try not to be like hanging out, like talking to friends, or trying to be doing it. Don't watch TV and eat. So try to do just only eating, taking the pills. Don't do anything else, even though it seems like not that big a deal. But just having that multitasking and not thinking about, not 100% on swallowing, will also make it a little bit more discoordinated. But your the speech therapist this afternoon will have a lot more ideas like that to make that less happen.
Dr. Catty, you want to take the
Sure.
CPAP question?
So the question is, I'm on a CPAP, and during my sleep study, I stopped breathing for 82 seconds. So I guess my first question is, I don't know who the audience, but that sleep study, was it pre-CPAP or was it on CPAP? So clearly, if it's pre-CPAP and it's just a baseline sleep study, then your CPAP should take care of that, or some kind of PAP device should take care of that breathing pause for 82 seconds. If it's on CPAP and you're still having breathing pauses, then the CPAP machine is not the right machine. You need a different PAP machine, probably a machine that has a backup breathing rate that can kick in when you have a breathing pause despite having the positive air pressure going in. So those are the BiPAP, the more advanced BiPAP machines, or what we call the ASV machines. So it depends on what you mean by this question. The second one is, I find I hold my breath a lot during the day. What can I do about that? So it depends on, sorry, my phone's going off here. So it depends on, I guess, without seeing the patient, it's hard for me to really answer this in a simple way, but I would start out with at least doing breathing tests during the day to see if there's any breathing impairment during the day that may make you feel like you're trying to breathe but you can't. So that's one thing I wanted to look into. And the other thing is, if you have more advanced disease and it's affecting or the breathing control center in the brain, you could have central apneas during the day, so that would be where you just stop breathing momentarily, but you're wide awake. So again, it depends on where you're at in the stage, but I would probably do a comprehensive sleep and breathing evaluation in that sense by doing daytime breathing studies and nighttime studies as well.
Okay, we'll get back to the autonomic question. So I'm going to combine, two of these are on the subject of medications. The first is Northera covered by Medicare? Answer is no, unfortunately, at this time. But we have some representatives from Lundbeck here that we can discuss with as well. Hopefully in the future will be. And then the second question is, this is kind of a detailed question. A patient takes 3 medications for orthostatic hypotension: Florinef 1 dose, Midodrine 3 doses, pyridostigmine 3 doses. But by bedtime at 9 or 10 p.m., I'm having low blood pressure symptoms and feel terrible. My doctor said I shouldn't take meds after 4 p.m. What do I do? If I go to sleep, my blood pressure is up. So I would say it's okay to take some of these medications later than 4 p.m. I would say 6 p.m. would be okay, maybe around dinner time. Usually you just want to avoid these medicines about, I would say, 3 hours before bedtime. The Florinef I always advise to take in the morning. It's usually a once-a-day medicine, so take in the morning, and then the other ones 3 times a day, morning, lunch, and then late afternoon or dinner, depending on when you're having your symptoms. The treatments for the supine high blood pressure, the high blood pressure laying flat, again, raising the head of the bed. Sometimes if the blood pressure is really high, we'll even give a medicine to lower the blood pressure at night, like a short-acting medicine for high blood pressure, like Captopril or one of the typical hypertensive medicines, but at very low doses. So, do you agree with that? Okay. And then I will give this one to Dr. Girardet. This is a follow-up on the sweating. What causes intermittent fine mist, generalized cool diaphoresis, leaves skin feeling very cold?
So normally when you sweat, you actually you do so to cool yourself down, right? I mean, that's why you sweat. You want to cool yourself down. But again, because of the degenerative process involving some of the temperature regulation in the brain, you tend to feel sometimes excessively cold. So it overshoots in both directions. Sometimes if this is a very uncomfortable symptom to the patient, then you probably should give a very, very gentle dose of something that reduces the amount of sweating. And there are some medications that do so. In my experience, usually, if the patient has that symptom, it often is probably because they are on a higher dose of midodrine. So I've seen when patients tell me that when they cool down, they are really shivering and their skin is very, very cold, they probably are slightly overdosed on midodrine. I then either reduce the dose of the midodrine or space it out a little bit more, and that often takes care of this symptom. But if it's not, then maybe you should give there are some, topical solutions or things you could do to reduce the amount of sweating, and that usually reduces the amount of cooling.
We've reached the end of this session. We're going to do our best to just address the last of the questions that came in, but we're not going to be able to take any more questions at this time. We do have another panel, an interdisciplinary panel after the break, and there will be the opportunity for asking more of our medical professional team from Stanford to address those questions. So, Dr. Miglis, do what you can to address the last of the questions that are in, and then we'll break, okay?
So this should be a quick one. Could RBD contribute to cognitive decline? Well, the answer is they're related. So everyone with RBD, even if it's only RBD, has some mild cognitive decline, because if there is RBD, we know that there's a problem with the brainstem, and if there's a problem with the brainstem, there's usually also, a problem with some of the cognitive centers. So I would say those are very much correlated. And we can have one more CPAP question, or maybe the trach question. That's a good one.
Yeah, so this is a complicated question. I have had a trach for 20 months and would like to have it removed. What are the risks? I have a G2 for nutrition. So it very much depends on the reason for the tracheostomy in the first place. Was it because it was an acute hospitalization, you had pneumonia? Was it because for vocal cord paralysis? Is because you can't protect the airway and you have aspiration risk. So it really depends. I will say for sure, if it's for the vocal cord paralysis, you cannot get the trach out, because it's a progressive condition. If it's because of an acute event where you had pneumonia and they couldn't take you off the ventilator and you got a tracheostomy, then there's a chance we can decannulate and get you off the trach. So it really depends on the reason for the tracheostomy in the first place, where you're at now, if you can protect your airway now, if you can breathe on your own now, can you breathe with a CPAP or a BiPAP machine? So there are many reasons for this, and I'm happy to talk offline after this is over. So.
Maybe one last one for Dr. Girardi. I'm a diabetic with neuropathy. Does MSA cause flare-ups more frequent in the feet and legs? I'm assuming that's pain.
I assume if it's pain, probably not much of a relationship, really. I think if you have lots of pain in your feet from a diabetic neuropathy, I would not expect MSA to have either one way or another. I would just be worried about, aggravating the risk of orthostatic hypotension, because now you have two problems causing potentially orthostatic hypotension.
And then one last kind of autonomic question. Could you speak to the effect of anesthesia on MSA patients? My husband needs surgery for an unrelated issue. It's a difficult question. I don't think there's anything that we're going to specifically change with medications, just to make sure that the surgery team is aware, that you have labile blood pressures. But, during surgery, there's always an anesthesiologist there that's going to address any of these changes with medicine, and we'll be monitoring all of these things very closely. You want to?
I think the one last thing, when we think of anesthesia as physicians, we're not actually just thinking about just the medicine, we're actually thinking overall. So the two things with anesthesia, one is the airway. So airway MSA is different. So your airway, if you have stridor, if you have sleep apnea, so the anesthesia, when you have your pre-op, you just need to talk about that, whatever airway thing you might have. Number two is even hemodynamically, remember you have lower blood pressure in general. When you give anesthesia, that is a little worse. So they just need to know those two things, your airway stuff and your blood stuff, what is your normal lowest blood pressure, because they will adjust their anesthesia amount for you. But that definitely has to be talked about in pre-op.
Yeah, I fully agree, and I usually just recommend to my patients that, if they have MSA or are going to have a procedure, just think of it high-risk anesthesia. So if it's going to be in a place or a facility, clinic or hospital, just ask them if they have an anesthesiologist who's familiar with these medical issues. And we're always available to work with the anesthesiologist to help you.
Okay. Thank you, thank you, thank you. What a great session. We really appreciate all of your time and expertise.